Thanks everyone for your attention here. I'm going to talk about an actual clinical trial that I hope to be starting soon. Um, and it has the name Drive. This is just an overview of some of my research programs just for fellows out there maybe thinking about projects or things in that nature. I do stuff in different areas. Volume regulation is kind of a new thing for me, which is this one. We had some really interesting data come back just this week on our acute kidney injury study where we recruited about 270 people from the ICU and are finally getting data back. So there's a lot of interesting stuff going on with that. This has been sort of my side project for a while, but now is becoming of more interest. And so what I'm going to tell you about is a clinical trial to reduce dry weight in dialysis. It's something I've wanted to do for a long time. The application got a high score at NIDDK before the government shut down. So it may actually happen. This is how it goes with grants. You get a score and then you wait and wait and wait and try to email them about when it might start or what the decision is. And no one really tells you anything of meaning. And then one day the money either just comes or it doesn't. So that's where we are. But the score means that it usually, ones that are in the top, say 6 or 8% are usually funded. So this might actually happen. Okay, so what's the rationale for this trial? So most people, and you've heard some of this before from me, most people who initiate dialysis for end-stage disease are volume overloaded. The use of bioimpedance spectroscopy is one way that's been done to measure extracellular volume. It's not perfect. There's got a lot of different limitations that we can talk about. It's actually measuring fluid overload. But given those limitations in a large cohort of people from all over the world, except the United States, the average amount of fluid overload in people initiating dialysis was 2.7 liters with a real broad distribution. So on average, people who start dialysis are volume overloaded. And the problem is that even after some time, people who are on dialysis are still have underlying volume overload. And this is another study from 380 dialysis clinics across Europe, classifying people into their by their volume status. The patients had been on dialysis for 3.6 years, and most of them, not all, but most, had at least moderate fluid overload, as estimated by bioimpedance. And I think, there's a lot of different complications of having end-stage disease with the retention of uric toxins and the inability to regulate minute-to-minute electrolytes and things like that. But extracellular volume overload is just a terrible complication of end-stage disease. It leads to this invariable sort of uh, chain of bad consequences. About 90% of people on dialysis are hypertensive, 80 to 90%, depending on how it's measured and defined. This leads to ventricular hypertrophy and then arrhythmias, and then this vulnerability where even a cold can put you in the hospital with pulmonary edema, where the rest of us just get a cold. There's when you have extra fluid sloshing around looking for some place to go, and there's anything going on in the lungs, you get hospitalized for pulmonary edema. And it's not only bad physiologically, it's just bad symptomatically. Um, Trying to put on shoes with big swollen legs is just no fun, and it's hard to recommend people exercise more when they're going through that. And then the cost. Um, this is one study of 176,000 Medicare patients. There were 35,000 hospitalizations for volume overload in that group in the in dialysis patients, which was estimated to cost 266 million. So expensive, physiologically bad, and really bad for patients. There's actually a statement put forth from a symposium attended by chief medical officers of dialysis units across the country. This was back in 2014, and their conclusions were normalization of extracellular volume should be a primary goal of dialysis care, though it's not explicitly put there like it is, like things like mineral metabolism and anemia. They said additional ultrafiltration treatment should be considered, incorporating in-center, nocturnal, or home treatments. And they said randomized trials should be conducted to evaluate strategies to facilitate sufficient volume removal. So we're excited to see those guidelines put out there. Unfortunately, there's been a lot of clinical reluctance for a long time. in terms of achieving actual physiologically appropriate volume. And we kind of all know the reasons why. There's no cost incentive to do it. It's hard to do. And I think one thing that's not maybe uh, given enough weight in terms of the clinical reluctance is that we don't really know exactly what kind of benefits and risks that we're delivering with such a thing if we could do it. So the part about it being difficult, if it was easy to fix, I think we would be doing it more. And when we try to achieve physiologically appropriate volume, and I'll call it dry weight, the weight at which the body is functioning properly, the weight you used to weigh before you had kidney disease, the weight your kidneys, if you had a kidney transplant, where your transplanted kidney would set you, that physiologically appropriate level attempts to get there using intermittent dialysis. It's often beset by intradialytic hypotension or symptoms that develop during dialysis because the rate of ultrafiltration is exceeding the rate that the extravascular fluid can refill back into the vascular compartment. Dialysis patients are on a ton of antihypertensive meds, which causes hypotension before dry weight can be achieved. And then if you're a Seattle convert, there's also this idea that diffusive clearance is also contributing to the hypotension before dry weight is achieved. And this sort of, I think, illustrates some of the sort of the general issue. Intermittent dialysis treatments are often capable of removing the weight that's gained since the previous treatment. And that's why a lot of times the treatment's focus on removing what you gained between the last time you were there. In the United States, the average interdialytic weight gain has actually gone down over the years. It's now about 3.1% on average of body weight. So intermittent dialysis treatments can remove that. But if there's a ton of extracellular volume excess below that, it's very difficult for intermittent treatments to get at that. And so you can just keep taking off the little bits you're gaining, um, but you have all this extra underneath. And then there's this idea of like, well, if we could get all that off, and it is difficult, how much improvement would patients have? What's the size of the improvement, and in what characteristics? And which patients would benefit from this? Not everyone would benefit from achieving a true physiologic weight. What are the harms? And is there any sense that maybe you get a sustained benefit after that weight's achieved, even if you start to refill to some extent? There are historical studies going back into the 70s and 80s where they selected people who were receiving short intermittent treatments to get long 8-hour treatments plus concomitant tapering of their antihypertensive medications. And in these case series, usually two to 300 people, there's about three or four of these. 95% of the people in these case series achieved normal tension, which at the time was a blood pressure less than 140 without needing medications. So it's this kind of data that um, sort of motivate this textbook idea that most hypertension in dialysis is caused by volume. But if you look at the studies carefully, they don't really qualify as what we would think of as studies today. You don't know who they picked. They don't tell you who they picked for the treatment. There are no controls who didn't get the treatment for comparison, so you can't get the size of the effect. They never checked how such interventions affected how people feel, function, or survive, which are technically clinical outcomes. And they didn't investigate how long the treatment effects might last. And finally, this is just a hint of a rationale for sustained effects of achieving volume balance on hypertension in dialysis. In the FHN trial, when they randomized people to frequent dialysis treatments 3 times a week, 6 times a week versus regular 3 times a week dialysis, in the intensive group, there was early on a pretty rapid reduction in dry weight or in weight, in pre-dialysis weight. And that weight then slowly creeped back up again during the trial. But blood pressure, at least systolic blood pressure, stayed down throughout the length of the trial. Now, there's the data a little messy here, but it does give a suggestion that achieving fluid balance might have potentially biologically sustained effects, even when some weight is gained back. So the aims of this trial is in a randomized trial to test whether the two ultrafiltration strategies that we're going to talk about in a second can yield sustained reductions in blood pressure and symptoms of congestion, as well as other impacts on secondary outcomes that I'll discuss. At the same time, the trial will evaluate the safety of these interventions. This is our investigative team. We have some great people here and elsewhere to work on this trial. Okay, so this is where I am very welcoming of feedback. So please email me, or you can call me or text me, because we are writing the protocol, and what you say you're going to do in a grant and then what you actually do on the ground sometimes is different, as you actually have to put your ideas into actual practice. And so I'm always looking for feedback, especially for clinical trials that are focused on clinically oriented questions. In trials, we really try to balance internal and external validity, meaning for internal validity, if you had all the possible resources to identify the, the, the patients you wanted, say, but no one else could do that, then your results wouldn't be applicable. So if we did have some incredible machine that could just pinpoint those patients that are volume overloaded and would benefit from extra volume removal, we would use that machine. But if that machine was only available in one dialysis unit in Seattle, the results of the trial would be non-applicable. So we have to try to come up with definitions of these things that can be used elsewhere. My favorite example is the great study of sodium balance that was done in three Russian cosmonauts who were confined to a terrestrial space station, in which the results of the study really are internally valid. They tell you a lot about sodium balance, but the results are applicable only to male Russian cosmonauts who are locked in a terrestrial space station. So we thought when it comes to identifying people with suspected volume excess, it would be people with end-stage disease who've been on dialysis for at least 4 weeks and had clinically suspected volume overload based on either ongoing hypertension or symptoms of congestion. And this is under the assumption that having ongoing hypertension, in most cases in end-stage disease, is based on underlying volume overload. At least that's the physiologic assumption that we believe at this time. And that's an easy definition to apply. The symptoms of congestion, we're going to use this kidney modified Kansas City cardiomyopathy questionnaire score to define that. And I like this series of questions because it asks things like, how many times has shortness of breath limited what you wanted to do, and in what ways? And how many times do you have swelling in your legs when you wake up? And how many times do you have to sleep with pillows? And how far can you walk? So it's really about congestion and shortness of breath. And I think that was a good place to target the extracellular, the volume overload. Of course, other things can cause the hypertension and other things can cause symptoms of congestion. So the trial population might not be pure in terms of everybody having the volume overload that could be targeted by the intervention, but this is at present, how we're proposing to balance external and internal validity with a relatively simple definition for the study population. And by the way, a cardiomyopathy score less than 75 has been used in previous studies to indicate at least moderate symptoms of congestion. These are the current planned exclusion criteria. I can leave these up for a second for people to look at. And so again, just in terms of the population, we're really trying to figure out, we're going to be offering a treatment that's going to be reducing your extracellular volume. Who out there would benefit most from such an intervention and who would not, is what we're really trying to figure out, or who might not be safe or might not be the right population to test that. So the trial is structured such that people who are eligible for inclusion will be randomized in a 1-to-1-1-1 fashion, so 40 in each group, to one of three different treatments. The first is control. You get your regular 3 times a week dialysis, you get counseling on dietary sodium restriction, and that's it. The two treatment groups add either 4 or 8 weeks of this intervention, and the intervention consists of two extra slow ultrafiltration treatments per week for a total of 5 over that time period. And de-escalation of antihypertensive medications. Now, the 4 and 8 weeks might sound like a lot, but as I'll talk about in a second, it's up to. Because if you achieve a physiologically appropriate weight before that time, which we do expect many people will, then you graduate and you're finished with the intervention. And the idea here is to do the intervention and then to watch over time and see how long, if there are benefits, how long they last. Under the assumption that once you achieve a physiologically appropriate weight, that intermittent dialysis treatments can maintain that weight in many, but not all people. The ultrafiltration, the two extra treatments, it's going to be slow. It's going to start at a rate of 6 mils per kg per hour, and then it's going to be guided by blood pressure. If the blood pressure falls, systolic below 120 or diastolic below 55, or the patient develops symptoms, then we decrease the rate by half and then recheck. And if the symptoms or the characteristic is still present, then the treatment's terminated. Again, this idea is to use pure, non-diffusive clearance ultrafiltration at a slow rate on non-dialysis days to allow re-equilibration between days, and to take off as much as we can slowly. This just shows how much extra fluid we expect to remove under different assumptions of different patient weights and different fluid intakes. In the second column is the amount of fluid we expect that we're simulating the person to gain, in addition to that removed from the usual 3 times a week dialysis. So if you look at like this column that says 80 and 1000, this is an 80 kilogram person who takes in a liter more salt and water than is removed by 3 times a week dialysis. And under those conditions, we expect the ultrafiltration treatments to remove just under 3 liters in a week at the 6 mil per kg rate. At the same time, as part of the intervention, antihypertensive medications will be tapered and removed. And this is just the protocol for removing them and the priority order for their removal, starting with the medications we think have the least evidence for use, which are hydralazine and minoxidil, then clonidine, then alpha blockers, then non-loop diuretics, then ACE, then calcium channel blockers, and then beta blockers. There's some, controversy about this order because there's not great randomized trials of different antihypertensives. There are a couple, but they're relatively small. There's a lot of observational data. So this is the order we came up with. We will not discontinue anybody's blood pressure drugs if they're used for something other than hypertension. So like, a calcium channel for rate control and AFib, we don't stop that. And if they're on loop diuretics to maintain volume in dialysis, we keep those as well. And then this is just the protocol of how we do this. So they basically show up for an ultrafiltration treatment. If they're at goal blood pressure wise, but they're still on blood pressure medications, we're not going to ultrafilter them because the blood pressure is already low, but we'll de-escalate medications and have them come back. If their blood pressure is at goal without medications, which is really the goal of the study, is to get a normal blood pressure without having to use medications. If you get there, and you're on no blood pressure medications except those that are used for non-blood pressure indications, then we hold and check one more time. And if you again have a normal blood pressure without medications, you're done. So you get to graduate early from your ultrafiltration intervention. And then we watch. There are many outcomes of the trial. The main ones are the change in continuous ambulatory 24-hour blood pressure from the beginning of the study to the 24-week period. So we are hoping for and looking for a potential sustained effect of achieving this volume on blood pressure over 24 weeks. We also hope to see a large reduction in symptoms of congestion over the time. And we are very excited to quantify how much improvement in symptoms such an intervention might have. We're also looking at 6-minute walk distance, hemodynamic measurements, dialysis-related fatigue, markers like BMP, and then how people like the intervention, including the providers and the patients. And the other outcomes you see here. The primary safety outcomes we're going to look at are residual kidney function and vascular access complications. Both of these were affected in the FHN trial. So people who received 6 times a week dialysis for a year, there was a faster reduction in residual kidney function in one of the two FHN trials, not the other. And there were more vascular access complications in both trials from accessing a fistula multiple times. So we're going to be looking at those, even though we're doing a much shorter intervention. Then finally, as sort of an exploratory, but I think sort of interesting outcome, we're going to look at hemodynamics during the study using bioimpedance. This is sort of the newest generation of the bioimpedance measures. Just as a just general overview, you put a probe on the radial on the wrist and on the ankle, so over the radial artery and the posterior tibial artery, and then the bioimpedance, at least this particular system, is really estimating stroke volume as the primary thing it's looking at, and then you can calculate cardiac output by multiplying stroke volume by heart rate. And in studies of right heart cath, people undergoing right heart cath, there's a really good correlation of stroke volume estimated by the bioimpedance system and the actual stroke volume measured during by the Fick method. But I think of more interest, this is a recent study that came out. It's a hard study to interpret, so I'll sort of throw it up there and we can just sort of think about it. There's this idea that you can use hemodynamics during dialysis by bioimpedance to profile patients and categorize them into different categories. And in this study, they just took a bunch of dialysis patients and they did a single bioimpedance measurement. I think it was every 15 minutes during the dialysis treatment. The ultrafiltration rate was pretty quick on average in the study. And all they're showing here is that you can classify people as to their response to hemodialysis in terms of what's actually changing. Is the cardiac output going down and the blood pressure going down? So we oriented the cardiac output or index is on the x-axis and the blood pressure is on the y-axis. And so 47% of the people dropped their blood pressure and their cardiac output in response to hemodialysis, suggesting potentially that you're either going too fast or there isn't any extracellular volume to get. And then there's 51% of people whose blood pressure goes up, but the cardiac index goes down, and vice versa. So they plotted the patients into these quadrants, and then the arrow shows you what happens after they stop the dialysis. And I think that one of the ideas was in the bottom left quadrant that in people who drop both their blood pressure and their cardiac output in response to dialysis, if you then wait 15 minutes and see what happens next, for those whose cardiac output and blood pressure starts to return back to where they started, that might suggest that the cause of the drop was a rate that exceeds refill because they were able to refill and get back. Whereas those who stayed down in the bottom corner were at their quote unquote dry weight. This is very preliminary stuff, but we're going to collect it during the study 'cause I think it's interesting to see hemodynamically how people respond to ultrafiltration alone done this way, and we'll get some new data there. Finally, power. We hope to recruit 120 people for this study over 4 years. We assume a 10% dropout rate. And given some assumptions about our primary outcomes of blood pressure and congestion symptoms, we will have 80% power to detect a 3.8 millimeter of mercury difference between the groups in systolic blood pressure and a 3.6 point difference in the KM KCCQ score, where a 5 point difference is generally considered to be clinically meaningful. It's a lot of stuff. I don't know where we're going to start. I am really looking for lots of feedback and suggestions. I will be engaging all the NKC physicians and slowly kind of getting people into this, but I'm looking forward to your feedback and thanks for your attention.
All right. Thank you so much. A couple minutes for a couple questions or feedback. Anisha, you got your hand raised. Go ahead.
Great, thank you, Brian. Of course, I have some ideas about blood pressure. Um, So, two questions. Why 24-hour ABPM versus 44-hour, which is the standard in to look at the interdialytic blood pressure interval, and why a blood pressure goal of less than pre-dialysis blood pressure goal of less than 120, based on the evidence that we have.
Great questions. The first one, there is one paper comparing 44-hour uh, ambulatory blood pressure to 24-hour, showing they had similar results. It's an okay paper. 44 hours seemed very cumbersome, and so just having that evidence that the 24-hour yielded pretty good data compared to the 44, we picked that. As terms of the blood pressure goal, as you know, we have no randomized trials to understand what the blood pressure goal is, and there's a U-shaped curve in epi studies that probably suggest confounding, but who knows? And in the general population, of course, we have real evidence that 120 is the place to be, um, as long as you don't mind falling a lot, and getting AKI. So for this, I was at 130 over 80. Our team of investigators met last week, and there was some suggestion of moving to 120 over 80. So that one's really still in flux.
I would encourage you to look at the BID clinical trial, which was a ran RCT of two pre-dialysis blood pressure targets, 140 less versus 155. It may be helpful.
Mm.
Mhm.
Yeah.
Um, Leah, did you have a question or comment?
My question was the same. The 120 over 80 seemed really low
Low.
to me, especially if that's going to be the pre-dialysis blood pressure that
Yeah.
your people are going to show
This,
up at. So, yeah.
yeah, this is a great question. I don't, and I think this one's really still in flux. I think the question, there, so there's two different populations that are entering the trial, right? Those who are hypertensive and those who are primarily entering for congestion symptoms. And one of the questions the reviewers raised was, how are you going to help people whose blood pressure tends to be low and are congested? Um, and I think the answer with what you guys are saying is that we probably can't help them. Like if their pressure is 115 over 70 and they're really congested, this trial probably can't help. So maybe we should make the blood pressure target higher, and another trial can try to help people whose blood pressure is low. It's just that ultrafiltration and think maybe isn't the answer for them, or maybe you could do it in an even slower way, but maybe we don't know how to do it yet. Is that
I mean, yeah, I guess, I mean, I think we can help them even though but I realize that's not the question that you have necessarily, or you're, so.
well, it is. I mean, the goal of the question of the trial is to help people either to lower their blood pressure and get them off meds, and to make them feel better on their congestion symptoms.
But you're not going to UF them if they're under 120 over 80, correct? Like,
Yeah.
okay. Even if they're still having congestive symptoms. So you're
Well,
not,
that's the thing. I mean, I
yeah.
could propose, going lower, but I'm already hearing a lot of pushback, even getting to 120.
Well, that's for people who are just getting it for,
We,
that's that's just the pushback is against the target of 120 over 80
yeah.
for asymptomatic people, I guess. So not against symptomatic people. I wouldn't treat them the same. But anyway, sorry, I'm talking too much. Let other people.
It's really the heart of the where to stop is that, and in
Right, right.
trials having to have a number where in real life we would probably have a more nuanced approach to it.
Mhm.
A couple more questions. I see Yoshio and Captain both have their hands raised. Yoshio, you want to start?
Hey, enjoyed your talk, Brian, as usual. One of the ways, and I'm not a very good salesperson for hemodialysis, is that I sort of play it off to patients as you sort of give a day for a day, where between the travel, the treatment itself, and the recovery, they're sort of giving almost their entire day to the treatment. And then typically, the following day they'll have to do other things. And I guess when I'm thinking about this, now you're asking them to give 2 or 3 days for maybe that one good day. And one of the things about FHN, the frequent hemodialysis network trials, was that we saw improvements in blood pressure, phosphate control, LV mass, But one of the things we didn't see any significant improvements in is quality of life. And a lot of the concerns were around sort of caregiver, patient burden, and then also treatment burnout. And I was just wondering, maybe I can get your thoughts on that.
This is just a great question. Everything you said is absolutely true. The hope here of give a day, get a day back. The hope here is that maybe we can do a sort of very short, condensed period and then go back to regular dialysis and have a sustained effect over a long period of time. But to me, this idea of give a day, take a day, we don't know enough about the size of like how much improvement in symptoms might happen if we specifically target volume to be able to tell a person this is what you would expect to get back for your time in. I just don't know how much, if it's a 50% improvement in congestion symptoms, well, that's something we could say. But if it's like a 50% improvement that just comes back again 2 weeks later, it doesn't keep people out of the hospital and things like that, well, then it's not worth it. So that's exactly the question I want to start to answer. Catherine?
First, I'm excited about a trial that looks at volume management in ESRD patients. I think it's probably one of the most, I think it's one of the hardest things that we do. I do think, I think I was going to ask about really what you said one of the reviewers talked about, or one of the people around, what do you do for those patients who are congested with blood pressures that are not necessarily dangerously low, but are low? And I would love to maybe sit down with you and think about that a little bit more, because I think it's not an insignificant number of people, and I think there's a huge quality of life issue there. I will echo what Nisha said. I think for recruitment, if you say you're going to target a blood pressure of less than 120, based on many of our experiences with the recent blood pressure of trial of less than 140, you're going to have recruitment problems. So I'm totally honest, or at least I worry that you would. And so I think that there has to be sort of more discussion around that. And I love that you're looking at residual urine output, or residual kidney function. So, in hearing you initially talk, that was one of my, primary concerns. And I just really appreciate you looking at that.
Great, thanks. I think if we do that with iohexol, we originally proposed to do it with iohexol. I was hoping to do it that. Then it's going to depend on the budget. If we do actually do it with iohexol, there's an opportunity to actually measure extracellular volume directly by just getting an iohexol early on. So not only will we have residual kidney function, but we should be able to measure or estimate extracellular volume as we're going along, which would be fun. I completely understand the issue of blood pressure, that all the interventions are designed to be stopped immediately if anyone develops any symptoms whatsoever. But I'm happy there's no exact answer to this. And it's great to sit down and hear your thoughts on how to deal with the blood pressure, especially in people with symptoms, but with low blood pressure.
All right. Well, thank you so much, everyone, and really great discussion. I think for the sake of time, we've run over a little bit. I think we should adjourn, and then we are off next week for ASN, and then we'll return the following week with another virtual grand rounds. Thank you, everyone. Have a happy Halloween, and we'll see you all in a few weeks.